This is really a report to industry and investors. Kind of the foundation of it was a systematic review. And a systematic review is used to synthesize data and to help us understand a lot about a particular topic. And in this case, it was virtual musculoskeletal solutions. The actual systematic review itself and anything else in the report did not go through a normal peer review process, which would be common and which would be standard practice. But the fact that it did not go through a peer review process basically allows whoever's writing the report to frame the findings in whichever way that they feel like they want to frame them.
All right. So welcome to the show. We have Megan Donaldson and Jake Magel. I am really excited about this session today. I think it's a topic that is going to be of interest to a lot of our PT colleagues. And I couldn't imagine two better people to really go through this this information with us today. And so again, welcome Megan, welcome Jake to the podcast here. Megan, you're not a stranger to this podcast. It's actually interesting because you're actually a host, and now I'm hosting a host. So this seems a little bit awkward and weird, but I'll see if I can do my job the way that I'm supposed to do my job. But I'm sure certainly happy to have you on there. And Jake, I know that you've probably been on many podcasts, maybe none as exciting as this one, but I'm sure that you've been on many podcasts, so you know exactly what to expect, I suppose, here as well.
Not as exciting. That's right.
That's right. All right. So, I wanted to get into a little bit of this conversation specifically around the report that was recently published. And, I think it's probably worth noting that many of us probably have no idea what this report is. And I guess the first question that I have right off the top here is, and Megan, maybe this is the question best addressed to you. What is this report? What is it all about? I mean, I know that I wouldn't have seen this report, especially without, your bringing it to some of our attention and such. But so if you can give a little bit of background to our listeners, that would be fantastic.
Yeah. So, oftentimes what you find is this is a report that falls under like market research, which aims to inform market decisions, funding, even healthcare policy. I mean, this can have some broad reaches. So the fact that this came out, I would say probably early summer, and a lot of people didn't hear about it or talk about it because they were just kind of, it was kind of more hearsay. Many of us aren't in the funding areas of virtual MSKs, which we'll talk about the digital health technologies. But there is actually a group called the Peterson Health Technology Institute, which evaluates these digital health technologies. And the commercial interest and funding interest behind them. So that's really what started this project, which is it's a market research project. They want to know, is there resources here that people should invest in, and what could those investments look like? Could it save money? Is there an economic value? Is there an access value? And then how can that shape healthcare going forward? So it could impact policy. And that's where some of these groups have been out there for a while doing this in various pieces, but this one's specific to us in virtual MSK.
No, that's great to hear. And I think anytime that we start talking about AI and virtual health, things that probably matter to us a lot as physical therapists, most of us are probably, well, all of us are native more to the setting where we are actually working in the environment with the patient. I would imagine that some of it is, it's obviously exciting. I think we're on a new frontier and there's things that we can look forward to, especially as we progress and such. But, I guess another question that I have for you is why is this report really essential for us to talk about today, especially as I just mentioned, manual therapists. Obviously, a lot of our listeners are probably manual therapy listeners. And if they're manual therapy listeners, they're orthopedic PTs who, we put our hands on patients and we do these sorts of things. So why is this so important for us to discuss today?
Yeah, so the report is super interesting to read. So I'll state that first, which you should read the report. I think it gives you insight into the way people perceive our profession. And I'll be candid. I think some of this starts in the research. I think some of it is, what is PT? What is typical PT? And what we see is that people believe that exercise can be done more efficiently. And so they started to look at these MSK reports. And some of this was, I would say, couched as an access piece. If you read the report, there's some limitations of our profession, right? They did identify that there would be some workforce demands around 17% in deficit, like that we definitely needed to have more PTs in the workforce. And then the other areas of that is actually in the rural health areas, is some of that access and workforce needs are much greater. And so they kind of couched it as an access workforce support for virtual MSK, again, knowing that PT sometimes takes a little bit of time to get into. So having this as a easier access point was one of the pitches as why these may be viable solutions for healthcare support. So I think you have to appreciate that was some of their gap. That's what they see that these tools, the virtual health tools, would support. And they identify it as being like for patients who have mobility limitations, work commitment limitations, or geographical barriers such as living in rural areas with low access to getting to in-person PT sessions each week. So I think that's what we have to understand, the context to that. But when we actually appreciate the virtual technology, so, Derek, when you say like AI may be different than these virtual technologies. And I think we don't even talk about AI generated per se in this. There's going to be specific things that we say that are included in this study, but there's a big reach that's happening. And I think we have to really inform ourselves. What is this? How does this have impact to our practitioners on the daily? And some of it is understanding how our profession is seen. What's the value of PT and what is it they need to come to a provider for versus what can they get through this interaction, which has maybe little or no human interaction at all with a PT. So I think this is a key piece. It's also an advocacy piece. This report actually, so interestingly, kind of puts into question the value of PT campaign. I would actually say the economic value of PT. We show in the APTA's document, which I so value that piece too, is that we are a economic value for a lot of MSK conditions. That includes low back pain, carpal tunnel, knee osteoarthritis, lateral epicondylalgia. I think they called it lateral epicondylitis in the studies, but that we actually have value in those areas and that we are a low-cost option. And so interestingly to me is that in this virtual health report, they did look at knee, they looked at low back, and still trying to make it more economically feasible. So again, just kind of looking at, we are already a low cost option, so making us even more low cost, I would question some of the gain there. And then just the other parts of that is that we have to appreciate what you had said before, which is virtual health may be PT, but it may be coaches not trained as PTs. It may be AI. And I just think we have to appreciate that we're not seeing this virtual MSK happening on other professions like chiropractic, where there's more hands-on focus. So I just think we also have to advocate that like PTs do more than just exercise, right? And I think we have to learn to advocate for that as well.
Yeah, I appreciate that. And actually, I glanced at the report too, just full disclosure. So definitely there's a discussion around that, obviously, around the physical therapists or clinicians or whatever it might be that could be providing some of these services. So I think that last piece that you brought up there and the value of what we do and what we distinguish ourselves as is certainly an important piece of this equation as it looks there. It's interesting too that you bring up, there's, obviously if you look at the report and you sort of brief over the report, it could be viewed as something that seems relatively positive, right? Obviously we get a lot of our information, and some of us actually probably use app technology to help us with various aspects that we have in our life. But understanding our role and our importance, I think, is really key there. So I appreciate that answer there. So Jake, you're going to get on the question board here pretty soon, but Megan, I've got another one for you. So could you kind of, we've been talking about this report And I think a lot of our listeners are probably like, wait, tell me a little bit more about this report. What are you talking about with this report? So a little bit of the cart in front of the horse there, some, but give us an overview of this report. And if you can you outline some of those options that they highlighted in this report for treatments and such?
Yeah, that's a great question. So, what I would first say is that you have to appreciate they kind of categorized the types of digital health technologies that they wanted to focus on. So, the technologies that they put three different categories: so PT guided solutions, app-based exercise solutions, and then remote monitoring. And so, each one has, I would say, different levels of PT interaction. And so, again, when you read that, I think that's a really important piece because they do some direct comparisons, and maybe even I would say this will dive into some of Jake's conversation pieces, but about what the findings actually mean from a clinical practice perspective. But PT guided solutions may have moderate level involvement from a PT. So again, definitely they are, I would say, a little bit more simulated or similar to in-person PT. And so they did a lot of comparisons to in-person PT with these PT guided solutions. The app-based therapy solutions used some app monitoring, some activity engagement such as adherence tracking, but typically the PT set up the treatment plan, but then after that it was like a little bit more hands off. So again, I think you can appreciate that the app-based may not have as much interaction. It would typically set them up and then kind of go to minimal to no interaction at all. And then remote monitoring were actually supplementations used in addition to in-person PT. And this one is what would they use is billing codes as RTM, so remote therapeutic monitoring. So that would be in addition to in-person PT, this would be the augmented piece. This would be some additional things that they were doing. So those are the three categories that this report generated around those types. They did talk a little bit about rural health as being one of the aims, but really their studies didn't focus on rural health access. So remember, those who live in rural health may not actually have great Wi-Fi. And so some of these technologies and barriers and challenges weren't really detailed out. So I think we have to appreciate that report piece. But then the last thing I feel like you want to know just before we get into the studies more is that they prioritize some assessment pieces, which if you think about it, there were two pieces that they looked at. They looked at in-person PT and usual care. And so heterogeneity is pretty large when you think about in-person PT and all of these conditions and diagnoses. But really with that, it didn't prioritize it had to be hands-on. It didn't prioritize what those interventions specifically were. And again, I think we have to appreciate in-person PT, a lot of range of interventions. The usual care is actually what we would see in some other studies, is again where it's not PT. That actually usual care is medications, which is over the counter, application of ice. They may actually get some education, but most of it was like PT visits or no care at all. So again, each individual study kind of reset their own standard, and this study that was included in the virtual health kind of categorized those. Are those in-person PT interventions, or are those usual care interventions? And that's kind of how they dichotomize them, but a ton of heterogeneity within each of those studies. So again, just to kind of give you a high level overview of the way it was organized.
Yeah, so basically comparing something highly variable to something that's highly variable. We know where that can go, right? And so, all right, good to hear. Jake, you've been quiet here now. We've got to get you. I feel like you're ready to roll into this as well too. But I wanted to get obviously as a background in research and NIH funding, and somebody who has contributed a lot to our profession. I remember you've been on a lot of studies that actually probably do compare usual care, PT, those kinds of things in the infancy of when we were looking at those kinds of questions, specifically with hands-on care. So I think having you on here as a guest is really, really key and important. I think it really validates some of this conversation that we're going to have here. So appreciate you being on here. So we're going to go in a little bit into this because this is sort of it is a sort of a marketing kind of a thing, but it's also set up to look like it was a research being done. And so I think it needs to have some of that criticism there. So I wanted to ask you, why is it important to then critique this document, and especially that it's not a peer-reviewed paper, and it's not necessarily maybe intended to be a peer-reviewed paper, but I think it's warrants that critique. So why is that important?
Yeah, great question, Derek. Thanks. And I think it's important just to retouch on the fact that, yes, this is really a report to industry and investors. And as a part of this report, kind of the foundation of it was a systematic review. And a systematic review is used to synthesize data and to help us understand a lot about a particular topic. And in this case, it was virtual musculoskeletal solutions. And when you do a systematic review, you register the review with an organization, and which basically you basically tell an organization what it is that you're going to do in the systematic review, so that people can come back and then check your work and make sure that you did what you said you were going to do in the systematic review. So they actually did that. But then, as you mentioned, it didn't. The actual systematic review itself and anything else in the report did not go through a normal peer review process, which would be common and which would be standard practice if the report were to be published in a scientific journal. And so, it really subverted might not be the right term to use, but the fact that it did not go through a peer review process basically allows whoever's writing the report to frame the findings in whichever way that they feel like they want to frame them. And so some of the things that, to me, that were a bit concerning, well, let me just first say that the report included both randomized trials and observational studies, and the great majority of the studies in the systematic review were observational studies. And it's important to know that kind of the gold standard for determining effectiveness of an intervention is a randomized trial. And observational studies are subject to lots of different types of bias that typically are not present, or present in lesser amounts in randomized trials. And so it's just important to realize that when we're talking about making recommendations about the effectiveness of an intervention, when we have the great majority of studies in a systematic review are studies that are really subject to bias, then that should just give the reader some concern. And I think that in the report, they did report the level of bias, and they evaluated bias using standardized methods of evaluating bias, both for systematic reviews and for observational studies. And they found that about 75% of the studies that were reported in the systematic review had high levels of bias, were rated as having high levels of bias. And so that, when you put that together with their strong recommendations for immediate adoptions of these musculoskeletal solutions, I think it should just give us pause to make that leap to immediate adoption of these solutions in the presence of high levels of bias. And I'm not sure that a peer-reviewed manuscript of the same systematic review would allow such a strong recommendation. And so, to me, I think that's important to point out here.
Yeah, I appreciate that. Yeah, as somebody that just published a systematic review and has had some history with publishing systematic reviews, yeah, I think one of the things that we're looking for, and maybe 20 years ago, we could just say, okay, the studies were bad, but here's the results, and take with it what you may. But we're a little bit more of an advancing research profession now, and I've noticed that even when I've tried to, get published systematic reviews, appropriately so, where we actually have to factor that bias into our recommendations, just not basically saying these studies were terrible and then here's our recommendations. And that would definitely go through that peer review process. And so appreciate that lens on looking at that, because I think a lot of times people don't understand how that can sometimes impact the results and the research and those sorts of things. And the peer review process certainly takes away some of that layering there. So yeah, that's great.
Well, if I could also point out something else, is that there's something called the grade, which is which is a way of basically assessing risk of bias, or it's recommended that systematic reviews and other types of publications like guidelines use an overall evaluation for evaluating the quality of the evidence, and that is called one thing that's recommended. One version of this is called the grade, and grade is a quality rating that can be applied to the evidence essentially, and really what it does is the researchers then use this grade to say that they have that there's their level of certainty regarding the findings of the studies is very high or very low, and and although this is recommended for systematic reviews to use the grade, it wasn't in this case. And so, again, I think that we just need to be aware of these, what I feel like are shortcomings in the conduct of the systematic review.
Yeah, no, great. Probably brought that up there. So you kind of mentioned this a little bit, but can you tell us a little bit about the studies and why the listeners may need to read the report cautiously? You've mentioned a little bit of that, but maybe you can expand on that a little bit too.
So I think that just to reiterate that we had 9 clinical trials, randomized clinical trials in this systematic review, and 27 observational studies. And among the clinical trials, 6 of the 9 were reported as having high risk for bias. And among the observational studies, 21 of the 27 were reported to have high risk of bias. And so why we need to be concerned about this is when you have risk of bias in a clinical trial or observational study, is that essentially it can impact the results and you can get a potentially a misleading result. And so that's the big picture of why we need to be concerned about risk of bias and these high levels, particularly high levels of risk of bias. Remember, 75% of the studies in the systematic review had high risk of bias, yet the reports suggested that we ought to immediately adopt these musculoskeletal solutions when the risk for misleading results is high.
Yeah, and I guess one of the things that I'm just thinking about here right now is, I think a lot of our listeners might be looking at this and saying, especially if they look at the report and you just read it kind of quickly and you forget about some of the things that we talked about here, you might say, wow, this is pretty interesting, maybe even alarming, right? Like, wow, holy cow, we've got ways that we can, or things that might even, oh no, we could be replaced in a certain way, right? I think that that's some of the fears and the concerns that a lot of industries are going through. And maybe we've always felt a little bit protected around that in physical therapy because of that. But now we're seeing that infiltrate into what we are doing. And I think what I wanted to get at here was especially with the research aspect of this. So, all three of us are a little bit nerdy in our research ways, and some of us more than others, Jake. We look at things very differently, maybe than say clinicians might look at things, or certainly the consumers, right? I think that's actually probably even a bigger population that might see this and say, "Hey, this is fascinating and interesting." And actually, it was just today that I perused my social media, and I'm on like these runner group pages, right? And on the runner group pages are always like putting a picture of their leg and saying, I have pain here. What is this? Mm-hmm. And then you have a lot of people that provide input and, opinions. And, we ourselves or other people are probably doing this. It's like, okay, I'm not going to type anything. I'm not going to type anything because you just really can't. But that's kind of what this is a little bit like. But like you said, this is such a big stakes thing, where it's replacing something that is so important. Whereas in research, what I think is most alarming with this is that research we know takes 5 to 7+ years for findings to then translate into clinical practice. And that's research. The unfortunate thing with this is that it's actually something that is put forth by industry that actually probably has a bigger engine in it than even our research bodies do. And I think that's probably one of the more alarming features of this is that, yes, while it didn't follow the research process like we say it should, the outcome and the potential fallout from that is actually much greater than in the research. So I really think that's really important and key for listeners to understand that process and that systematic methodology for being able to come up with answers and address those things. So appreciate that, Jake, a lot.
Yeah, and if I can just kind of reiterate that this is again being a report to industry. The thing that we're really concerned here is that there was no peer review process for this product, and as such, there's no way to let potential consumers, being clinicians, policymakers, and so on, any concerns that we might have.
And I'll add, I mean, so it's interesting, right? Is when you read in the top, the beginning of the document, it does have who contributed to the writing of this. And there was one PT, again, clinician. The rest of them were physician based. And so, again, that's who constructed the study. And when they looked at, getting some additional stakeholder involvement, they actually looked at more of those that were in the virtual health side of things rather than the PT side of things. I think that's a gap that I just want to re-highlight. And then I want a gap that PTs, we're not a dime a dozen. There is a wide range of what we do. However, it's usually patient driven, and they put a lot of different types of patients together. And then again, there's a lot of heterogeneity in the types of approaches that we use. And again, it just adds layers of what I would say variables that then muddy the waters into really the validity of what their findings were. So stepping back, saying maybe we didn't get the right input, maybe there was some risk of bias that maybe overinflated some of the outcomes from those studies, but now we're putting it out as a marketing product without that layer of complexity to state. It simplifies it, like there is more value in this maybe than what really may be there. It may be an overestimate.
Yeah, I would agree. I think hopefully a lot of our listeners do agree as well too, right? I mean, obviously probably our bulk of our listeners are going to be listening into this and having some concerns and hopefully feeling proud about what they do from an actual physical therapy perspective and the training that they've received and what they bring to the table when it comes to managing these patients and individuals with, lots and lots of problems. And I think the impact that we can have on society, I think all those things should be things that we should be really proud about. So I guess for both of you, what can our said consumers, our physical therapists, especially those that really believe in what they're doing in terms of either hands-on or being present. So it doesn't have to always just be hands-on the care, but being present in the moment, right, is also important. What can our consumers do? And is there sort of any kind of call to action to our, especially musculoskeletal practitioners?
Yeah, I'm going to step in a safe space and just say advocacy. But when I say advocacy, I'm actually being very specific. We need to actually understand the complexity around this problem. And part of this is just making yourself, first of all, a little bit more informed. Read this. The other part is that you also need to look at the landscape. I mean, so I need to say, and again, Derek, you brought it up in the beginning of the conversation, but AI is different than virtual health technologies that were grouped into this study. And the reality is AI is picking up even faster. We need to be prepared for that conversation. And I'm going to even say one of the major virtual MSK contributors was Sword Health that was in these studies. Again, not speaking bad about it, but I'm going to give you facts. The facts is that Sword Health just laid off 13 PTs in order to ramp up their AI technologies in their type of services. So okay, so the PT is going to have oversight. Who's verifying? How do we know that this AI isn't taking over maybe into areas that are concerning? I'm going to step into another space. So United Healthcare is now under a major class action lawsuit because they actually have algorithms that were used by AI to determine cutoff points of service. And so now they've cut off essential rehab services for those individuals with injury or sickness and Medicare Advantage beneficiaries. And there's actually a lawsuit on this. So advocacy. if you have patients who are seeking those technologies, they absolutely need to be aware that it may not be considered the same. If they're not getting the type of care, we have to think about how are our insurance companies now using AI and technologies to make decisions on how they're going to provide care benefit coverage to our patients. So this is really advocacy, as in, like, talk to your legislators, get active, and talk about what these technologies do to the patients that we so care to serve, not just with our hands on, but with our brains, that we ended up seeking so many years of degrees in education to best benefit. It's not the same as a coach, and I don't know that AI is going to do it in the same way with personalized care. I do think there's formulas, but I don't know that they're going to ever replace the human touch piece and the human conversation piece that is essential to what we do.
I really appreciate that answer. And I think, especially those of us that are a little bit involved in advocacy, maybe we think about it this way, but maybe it's time for all of our PTs to start thinking of it this way a little bit more so, is being proactive instead of being reactive. And a lot of things in the world, we can be a little bit reactive because the wheel moves a little slowly. But I think, as you said, the AI wheel moves a little faster in certain spaces than we can appreciate. So I think, not waiting to be reactive, because by that point, maybe far too late. We don't know, but it very well could be. So I appreciate that proactive advocacy response. Jake, what do you think?
Yeah, I just really agree with everything basically Megan said and that you said, and doing our best as physical therapists to find a seat at the table where decisions are being made about whether or not these types of solutions are going to be available for consumers, and so and that requires some work.
So, Jake, I think that's really interesting that you mentioned getting a seat at the table. I feel like in this space, especially with what we're doing in PT, there are a lot of tables in this, and I know that this is putting you a little bit on the spot. But have you any thoughts on what that might actually look like? Megan's brought up, I'm talking with your legislators and those kinds of things that can actually have impact on, swift policy changes and that sort of thing. But any other thoughts on like how that might look? I especially want your thoughts and your opinion, because you've been involved in a lot of different things like the, opioid misuse and different types of ventures and such. And I know that, so you've had seats at the table, and I just would love our listeners to hear how you get those seats at the table, what you've done in the past.
Well, I think that related to this, a seat at the table could be making sure that you have a good pipeline to your health system leadership when decisions are being made about what types of insurance options are being provided, and that could be, and it could also be actually banding together as local clinics. More mom and pop clinics banding together to figure out how you're going to respond to some of these potentially virtual solutions that might be pushed upon us, rather than being given really an option of whether or not to adopt it. And so being able to have kind of a critical mass in order to go to health system leadership and insurance companies to have these conversations and advocate for our profession, I think will be critical in the coming years, particularly as Megan mentioned, related to AI, because that's not going away. It's only going to accelerate.
Yeah, the competition changes a little bit there.
Mm-hmm.
Instead of competing with the clinician down the street, we're competing against something very different. It's a very interesting perspective.
Yeah, right. And it's going to be couched as access. I mean, so I think we really need to appreciate that. It's couched as access. Mm-hmm. I live in North Canton, Ohio, right? And so when we think about, where you live, Derek, and where Jake lives, I would say we're not in rural areas for the most part. I received a solicitation from the insurance provider of a local hospital systems around here that they're now offering Sword Health PT services. And I'm thinking about all of the access of PT local to here. Like, there's a ton. I was solicited. I don't live in rural health areas. Access is pretty easy. And so is it going to be one of these solutions? And again, it was through Sword Health. And now I'm actually more anxious, is it AI generated? And so here's another advocacy tool. Go through it yourself. That's what I'm going to do. I'm actually going to sign up for Sword Health PT. and I'm going to evaluate it. And then I'm going to write to the hospital system and the insurers if I see something that would be a high variation of typical practice. So start small. You can go big. You can have big conversations, but we can't put our head in the sand and pretend like this isn't existing in a current concern. We have to engage in the conversation. My bigger concern is how are these algorithms going to then decide who gets coverage, who doesn't get coverage, or when does coverage get cut off? These are conversations that we have to start to appreciate. In our science, we've come a long way, but we're not all the way where we need to be, even about dosage in all of the research areas that we still need to explore what is best practice in the various areas. So I would continue to encourage clinicians in the listening areas to make sure that they're doing best practice, such as the guideline based cares. I mean, we really do need to be at the top of our game for us all to unite together so that we don't have a low variation in our practice, and that's who gets picked on, and then it changes the practice profession for all of those who truly do believe in the best hands-on care, the best solutions for our patients. We definitely need to step up our game as practitioners too. So there's a lot of low levels of hanging fruit that we can do. There's some higher, bigger things that we need to target. But I think the biggest thing I can say is engagement and advocacy. Those are the things we have to start to believe that we can make a difference, and we have to start somewhere.
I appreciate that. Really good advice. This has been great. I really do hope that our listeners have enjoyed some of this conversation, this dialogue. It's not doom and gloom by all means. We're a wonderful profession, and I think that we should all be excited about it. And that's how we should actually walk away from this podcast, is who we are and what we do and what our identity is. But realize that there are people that are always wanting to have a little bit more say in this space, and we need to just make sure that we are, for society and for the individuals that we serve, protecting that space. So appreciate
we're
both of you
already
being
an
on the
economic
show.
value. We're an economic value. We don't need to be cheaper to just be cheaper. We need to be cheaper with high quality. And I think that's the piece we just can't lose sight of. We are already a great value. So we just need to keep the message consistent.
Yeah, there we go. Great words to leave on. Thank you, Megan. Thank you, Jake, so much for being on the show.
Pleasure being here. Thanks, Derek.